Welcome to Exploring Reality Maybe, where we explore the intersection of science, medicine, and mysticism with experts. Today, we're joined by Nick Sireau, co-founder and CEO of Seranatis Bio, a biotech company developing fast-acting treatments for obsessive-compulsive disorder. Nick's commitment to this effort is shaped by his own personal experience living with OCD himself.
As co-founder and chair of Orchard OCD, a medical charity funding academic research and through running a support group for people with severe OCD in Cambridge, UK, Nick has witnessed firsthand the devastating impact of this widely misunderstood condition. With a PhD in social psychology, he's now channeling decades of patient advocacy experience into developing novel therapeutics that could transform the treatment for an estimated 250 million people worldwide living with OCD. In this conversation, we dig into the neuroscience of OCD, explore why existing treatments fall short, discuss the promising science behind Seranatis' drug pipeline, and examine profound questions about consciousness, free will, and what it means to have a calm mind. Nick, what inspired you and your co-founders to start Seranatis Bio, specifically focused on OCD, and how has your personal and professional background shaped this mission?
Yes, thank you. So we set up the company a year ago. So my co-founder is called David Kavala. He's a neuroscientist, a chemist. He worked at big pharma like GSK, before that the National Institutes of Mental Health and Cambridge and small pharma and all that. And myself, I spent 20 years in drug development. I spent 20 years really founding and co-leading a consortium that worked on a rare genetic disease that affected my children. And that went very successfully. And decided then to focus on OCD for personal reasons. So OCD runs very deeply in my family. I have a number of family members affected, as well as myself. And I've been running a support group where I live in Cambridge for the past 10 years. And lost a very good friend 5 years ago well, he took his own life, basically, because he had such severe OCD. And when you look at the treatments for OCD, they're really not very good. You're given very high doses of SSRIs, or you have to go for very specialist cognitive behavioral therapy, which can work really well if it's done properly. But it's very difficult to access, at least in the UK, very difficult to access. So then really thought, well, it's about time we really did something. And so set up Seranatis to work on a number of drugs, really, that we're developing. Hopefully, what we believe are fast-acting drugs, at least that's what we've seen preclinically, to try and treat this awful condition.
And so Seranatis, what does that name mean? Like, why did you wrap this work around that name?
Yeah, so we came up with the name Seranatis, and it comes from the word serene. And anybody who has obsessive compulsive disorder, the one thing they really, really strive for is mental serenity. It's just having a calm mind. And the reason for that is OCD is not what most people think. Most people think it's about lining up your pencils and color coding your spreadsheets and being organized. It's got nothing to do with that. It's a devastating mental illness where people will be obsessing 24 hours a day. So from the second you wake up to the second you go to sleep, you're obsessing, sometimes even in your dreams. So what you really want is a serene mind. And that's why we call the organization Seranatis.
Yeah, that's wonderful. So I was going to ask you, and you sort of did it, but maybe you can go a little deeper. OCD, obsessive compulsive disorder. I think people throw the initials around a lot, and I bet a lot of our listeners might not even know what they stand for. Tell us a little bit more about the condition and maybe focus a little bit on how it's tested and diagnosed in patients.
Yeah, so, I mean, people have known about OCD for centuries. The French used to call it la folie du doute, the madness of doubt. And the reason for that is at the very core of OCD is a pathological doubting. It's the what if. And we now kind of know where that comes from. That comes from a part of the brain called the anterior cingulate cortex, this kind of what if. So you get, it comes in a range of symptoms. And often with people, it will fluctuate from one to the next over several months and years. But kind of the traditional form of OCD that most people are aware of are kind of the checking OCD, or the contamination OCDs. Those are seen as the kind of traditional ones. So, in the support group I've been running for the past 10 years, we have, people with very extreme compulsive checking who will be checking the light switch on and off for 8-9 hours a day, because they're just worried that maybe it's still switched on and that will create a short circuit and the house might burn down and everyone will die and it'll be all their fault. So there's a whole bunch of catastrophizing that's part of it, but it's the what if. And in the contamination OCD, people will be like, they'll touch a lamppost, then they'll suddenly think, what if that was contaminated? I better go home and wash, and they'll wash their hands. They'll still feel that there's something wrong. They'll wash again and again and again and again. It's this what if just going round and round and round. But you get lesser known forms of OCD that are just as common, but that no one talks about. One of these is what's known as false memory OCD, which is what my friend who took his own life had, and which is very common. It comes up a lot in my support group. And this is a form of OCD where people have false memories about often horrific events, So they might see something on TV about a murder and all that, and then they'll suddenly start to have kind of false memories about, a murder and start to think, damn, have I committed a murder and forgotten? Or what if this is true? Is this a real memory? Is it not real memory and all that? And they'll obsess about that over and over and over again. And they're the checking compulsion. They'll be checking their memory, So it's absolutely horrific. And then you'll get other forms, like you get religious OCD that happens with people with very strong religious beliefs, where they suddenly start thinking, well, what if I blaspheme? What if I, commit the unforgivable sin and all that? And so you get this whole range. And at the core of it is always this doubt, this what if, the obsession that fuels the obsession. And the obsession tends to link to the most horrific thing that you can think of. So it's what's called ego dystonic. It's the very opposite of who you are. Most people with OCD are very upright, and they really have a very strong sense of self-responsibility. And that's why they will be plagued by these kind of taboo thoughts, And then on the other side, you have the compulsions. So you have the typical physical ones, like you have a member of my support group who will get up at 4 a.m. To spend the time checking the whole house before she goes to work as a teacher, and then she'll drive to work and then she'll think, oh no, did I really lock that door? And then we'll drive back to check and take photos. And on the way, she'll be like, yeah, but is this a real photo? So there's a kind of semi-delusional aspect to it, of the compulsion, So it's a very devastating disorder. So the way it's diagnosed, generally, it's, really, in theory, it should be diagnosed by a psychiatrist, And they take you through the Yale-Brown obsessive-compulsive score, which is what also all the regulators, everyone uses actually in clinical studies, And I remember when I was first diagnosed, I was taken through this Yale-Brown obsessive-compulsive score where they divide your obsessions into a score out of 20 and your compulsions into a score out of 20, And so 0 to 8, you're more or less OCD free. 8 to 16, you're mild. 16 to 24, you're moderate. 24 to 31, you're severe. 31 to 40, you're extreme, And that's how they can track it and diagnose. And there's a whole bunch of other ways also of diagnosing and studying it. But that's kind of one of the key measures, basically.
So, Nick, my middle brother Joshua suffered from what they diagnosed as like a borderline schizophrenia, and he became paranoid, and it was determined that it was a chemical imbalance. Is there a difference between that kind of diagnosis or a chemical imbalance of the brain and what triggers a person with OCD?
Yeah, I mean, we've got a pretty good understanding nowadays of how OCD works, a pretty good understanding. I think of all the psychiatric disorders, it's probably one of the most understood. And that really surprises people. And there's been a ton of work. The science has really progressed massively in the past 10, 20 years. And a lot of the work we do here in Cambridge comes out of work done by the University of Cambridge over the past 20 years, particularly a professor who's one of our advisors called Trevor Robbins. Very eminent neuroscientist, just an amazing, amazing person. And he spent 20 years studying OCD. And more recently, he basically did a study funded by the Wellcome Trust where he recruited 30 patients with OCD. And he put them in a super high resolution scanner called a 7 Tesla magnetic resonance spectroscopy scanner. So 7 Tesla means it's very, very high resolution. And what he detected was an imbalance of glutamate against GABA in 2 parts of the brain, the anterior cingulate, which we just mentioned, and the supplementary motor area. and linked that, particularly in the supplementary motor area, to the Yale-Brown obsessive-compulsive score, which we just talked about, to the severity of it. And this was really quite seminal and groundbreaking, because until he'd done that, and he published that in Nature Comms a couple of years ago, nobody had shown any link between neurotransmitter levels and OCD severity. So this is very important. And since then, there was a major paper in Nature Genetics 3 months ago, okay, where for the first time, they really managed to identify 30 genes that they're now convinced are involved in OCD. Until then, there'd been a lot of candidate genes and stuff, but they basically amalgamated these huge genome-wide association studies and identified 30 genes, and a lot of them are on the kind of glutamatergic neurons in the anterior cingulate. So everything's coming together. But what's really exciting also in OCD, of all the psychiatric disorders, it's probably the only one where neurosurgery really works.
Oh, wow.
It's a last line treatment, but it really works. And again, they target the anterior cingulate. That's one of the targets. And deep brain stimulation works well in OCD. It's semi-miraculous, you know. So as I said, the existing treatments for OCD, you're given super high doses of antidepressants. So like sertraline, you know, for depression, you're given 50 milligrams a day. For OCD, you're given 200 milligrams a day. And I've even heard of cases where they're given 400 milligrams a day. And you wait 3 months to see if they work. Half the time they don't. Then you get all the side effects and all that. So it's not great for medication. But deep brain stimulation, I know 2 people who've had it. And they target, again, the anterior cingulate. And one of them, within minutes, her Yale-Brown obsessive-compulsive score reduced from 39 out of 40 to 19 out of 40. Now, obviously, it's very invasive, you know, and obviously there's a risk involved, which is much lower than people think, but there's still a risk. And it's for only very, very extreme cases. In her cases, she'd been in a psychiatric institution for years, you know. But it's quite miraculous. And so it again proves that this part of the brain, you know, is really one that we target. So it's a pretty understood disorder.
It's so interesting. And the anterior cingulate is not an area that was very prominent back when I was a graduate student, you know, 40, 30,
it's really
35, 40 years ago. Yeah. In fact, I had a neuroanatomist friend who was studying the anterior cingulate just from a neuroanatomy perspective. So it's funny. Otherwise, I might not have even heard of it. Anyway, that's a perfect segue, Nick, to sort of talk about Seranatis and your pipeline and your targets and kind of what what you've got in development. So why don't you talk to us a little bit about them? You know, the mechanisms of action that you're targeting, the timeline for coming through the regulatory process, and what kind of patients will respond to those molecules.
Yeah, absolutely. So we've got 3 different molecules. The first one comes out of work we've done again with Professor Robbins and another professor called Amy Milton. And what they have, and this is a drug that targets some of the mGluR receptors, so the metabotropic glutamate receptors. And this particular receptor we're looking at is mainly presynaptic. And what we're doing by targeting that receptor is that we're reducing glutamate, so reducing the glutamate GABA ratio. And there's a number of these mGluR drugs that have been into the clinic, you know, into clinical trials and all that. And so we tested a whole range of them in a rat model of OCD, you know. So you'll know generally in psychiatry, it's quite difficult to do animal models. But this rat model, which we call the Cambridge rat, is actually a very translatable model. And it's a model that's been developed here. And basically what they've realized is that there's a certain strain of rats called sign trackers who have very compulsive checking behavior. And apparently similar problems in neurocircuitry to humans with OCD.
So it's actually an animal, sorry to interrupt, it's actually an animal model for OCD. For our listeners who might, who might not. Okay, so you've got an animal model where you can now study the effect of certain agents on whether it's going to get better or worse.
That's exactly right. And so they put these rats in a box, and the rats have 2 levers that they can press on. And if they get the correct lever, they get a food pellet. But they don't know which one it is. And there's a 3rd lever behind. They soon figure out if they press on that one, a light goes on telling them which is the correct lever. So the normal rats, called goal trackers, will press once, see the light, press the correct lever, get the food. But the sign trackers, the OCD compulsive rats, will keep pressing on the checking lever, just checking a bit like the checkers in my support group. We'll just press and press and press and press and press, you know. And what's really interesting is the Cambridge group here did the same experiments in humans. And I think I was actually part of those many years ago, where they put you in a room and you have a box with 2 levers. And if you press on the correct one, you get money. And a third one tells you which is the correct one, And us humans with OCD, we keep pressing on the third one. So it's a very translatable model. And what happened when we gave these mGluR modulators to the rats, within 2 hours, their checking just absolutely plummeted, So when Professor Robbins showed me that data a couple of years ago, and it was actually published early this year, I was like, oh my God, if we could actually have a fast-acting medication, obviously we have to prove this in the human animal, that's the next step, that's the big thing. Right. But if we could, it would just be groundbreaking, particularly because these drugs do not seem to have the side effects of the SSRIs, So that's the first one. And then the second one is actually a drug that my co-founder, David, has invented. So David is a very good chemist and neuroscientist. And David spent a lot of time studying a very old French drug that was developed in the 80s that worked on the AMPA receptors, again on glutamate. Okay. And this is a drug that is approved in France for depression and a number of other countries, and was shown to work in a small study in the 90s on obsessive-compulsive symptoms. But it was never widely commercialized, because when the company that developed it tried to go to the US to commercialize it, people only believed in SSRIs. So what David, my co-founder, has done is he has tweaked it, so developed an analog that has much better selectivity for the receptors we're targeting and has a much longer half-life, because the original one only has a half-life about 2 hours, And so what we've done is we've tested that in another model, actually, in a mouse model of OCD. So we went for a different model there, again, with really good results, So that one's looking very promising. And that, again, that is based on the parent drug, which has clinical evidence, So that really does, because
what's the parent drug?
The parent drug is an old drug called tineptin.
Okay. Interesting. Okay.
And so we're not developing that one. We're developing the new one, which is much more selective. More selective.
So,
and then the third one, it works on dopamine dysregulation in the prefrontal cortex, basically. So it's been shown that if you can increase dopamine in the prefrontal cortex, you can improve cognitive flexibility, and you can help people detach from their obsessions and all that. And that's at very early stage. That's at discovery stage at the moment.
So it sounds like all 3 of these are, relatively early stage, right? You've got very, very intriguing animal data that suggests they might work, and you're not into humans at all yet?
No. I mean, you're exactly right. The company we set up a year ago. We set up.
Oh, okay, yeah. So that's actually a lot of progress in a year. Yeah.
So we raised our first round, our pre-seed round, about 4 or 5 months ago, basically. And that allowed us to do all our preclinical work. And we're now raising a new round to take us through, animal toxicology and then into clinical trials.
So what do you do? I work with a lot of companies in this stage, and obviously, there's a lot of risk and, there's a lot of aspiration, but, these molecules may or may not work. So what do you do to manage and mitigate risk in a company like Seranatis, against the drug's not working like you anticipate them to?
Well, there's a number of things. I mean, that's a really good question. The first thing, and this is where David's expertise comes in. So David's expertise, a lot of it is in a kind of an area of drug development called drug repurposing, And drug repurposing, I'll give you a very good example, actually, which is exactly what I did with my children's rare genetic disease. So I have 2 boys who have a rare genetic disease called alkaptonuria, ultra rare, 1 in 500,000, also known as black bone disease. And what we did over the past 20 years, we set up a consortium, and we basically took a drug that had been approved for another disease, and we got it approved for my kid's disease. So for that, we had to do some preclinical work, a phase 2, a phase 3. It was approved by the European Medicines Agency in 2020 and by the FDA just earlier this year, But drug repurposing is difficult because once a drug's been approved and it goes generic, there's no commercial incentive for anybody else to actually develop it. And that's why we had to raise large grants to do it, But what we've done here is we've used that concept. We've looked at what drugs do we know have shown some efficacy in OCD, but for all kinds of reasons were never widely commercialized and all that. How can we then look at the mechanisms of action, improve it, and create completely new drugs that are much better, see what I mean, and then take them through the development pathway, And that's a very good way of de-risking it. because you're basically looking at things that work, but for some reason or other, due to, commercial reasons or due to maybe some off-target side effects and all that, were never widely developed, and that's one of the core principles behind it. So you end up with a completely new drug, new chemical entity, new intellectual property, everything, just a much better one that you can then take into the clinic. So that's the first thing. The second thing is the precision medicine approach, and a lot of people talk about that. And that's really important in psychiatry, because in psychiatry, a lot of drugs fail at phase 2, which is when you go into your patient population, you're trying to show some degree of efficacy, and there's a number of issues there. So we use precision psychiatry. One thing we've been really looking at is using electroencephalography, EEG, and the group here in Cambridge have shown that there's 2 EEG biomarkers, one from the AC anterior cingulates, one from the supplementary motor area, that are linked to these glutamate GABA ratios. So we're looking at how to include those, into what we're trying to do, because that, in theory, might help figure out which patients will respond to the first 2 drugs. And the third drug, there's a genetic biomarker, actually. So there's a saliva test and a genetic biomarker that predicts how people respond to that type of drug. So that's precision psychiatry. And then the third way we de-risk it is really the fact that OCD has the lowest placebo response of any psychiatric indication, And there was a paper on that a few years ago where they did a meta-analysis of all 9 main psychiatric indications, schizophrenia, depression, bipolar, and everything. And they found that OCD has one of the lowest responses to placebo. And there's a very good reason for that. It's that, depression tends to fluctuate maybe from week to week, depending on events and all that. OCD, it is just always there. It is chronic. You're obsessing constantly. And what they call the intra-patient variability, so the variability within the patient, is actually quite low. So patients don't really respond to placebo in OCD studies. And what that means is you don't end up with the major problem that you get in many depression studies, where you just struggle to separate the placebo effect from the effect of the drug, So those are kind of the main ways that we kind of de-risk the whole thing.
Yeah, no. And again, it gets a little technical. I'd like to ask you to sort of go back. Our audience probably won't know what you meant by, and it's fascinating, and I think it's really important, by precision medicine and psychiatry. Tell us a little bit, about how we use in psychiatric medicine, as well as in other medicine, genetics and other genomic principles to sort of become much more precise about the target populations.
Exactly. So it's used a lot in cancer. People they take a biopsy from the cancer tumor, and they'll figure out what genes are involved and all that, and then use the medication, which will be particularly tuned to that particular genotype within that cancer and all that. And so, cancer is very precision medicine. In psychiatry, the brain is such a complex organ that we're just starting to get into that, So people are increasingly understanding the genes involved in psychiatric disorders. But it's very different, for instance, to my kid's disorder. My kid's disorder is a single gene, very rare, that then triggers and creates their genetic disorder. That's one gene. In a brain disorder like OCD, we now know of 30 genes, but there's probably hundreds. There's no single gene, But more and more, we're starting to get an understanding of which ones are involved. So the precision psychiatry, so for our third drug, we know that this particular enzyme that we're targeting, there's a gene that's particularly involved in that. On the more glutamatergic ones, the whole precision aspect is about using the EEG kind of helmet to try and get a better understanding of which drug will work for that particular population.
Very
precision. It's about
edge.
targeting,
Targeting.
And OCD is less kind of what they call less heterogeneous as, say, depression, but there still is a certain amount of heterogeneity, And so you have to try and get underneath that to really figure out which drug will work for which person. That's the precision aspect.
It's so exciting. We've interviewed a couple of other neuroscientists who have highly mapped the neurological movement of the brain to very specifically, for example, address depression. And then they bring modalities into that particular mapping to reverse or affect the person's symptoms. And their lives have, they've reported that their lives have just changed completely. So this precision, new mapping technology is super exciting around the way to address mental challenges. And I'm curious. I think populations have a real misunderstanding around OCD, and I think some of these modalities of medications and things like that are changing now with new treatments. And so how are you reaching out to mental health advocates, patient communities, and sharing sort of like some of these newer approaches that you're studying to sort of give hope to a new approach to treating these kind of symptoms?
Yeah, that's a very good question. So 10 years ago, okay, I set up a foundation called Orchard OCD, which is a charity, which is a non-profit and all that. And I'm still involved. I'm still on the board, although I stepped back down as chair recently in order to focus my efforts on Seranatis. But what we've done over the past 10 years with Orchard is to really try and build the whole ecosystem, in the UK and to a certain amount internationally. And so we've done a number of things there. We funded a study of a psychedelic, psilocybin, in OCD, a single dose, which showed some very promising results. We funded a study of neuromodulation, transcranial direct current stimulation. We funded a drug repurposing study. We also did a health economic analysis, because what we're trying to do is to help researchers apply for funding. And one of the questions they get asked is, well, how much is OCD costing the economy? And we basically we published it 2 years ago. We found that OCD costs the UK economy around £10.7 billion a year. That's around $13 to $15 billion a year. That's in the UK,
Wow.
And then we've also set up a registry because often people struggle to recruit for their studies, whether it's academic or whatever, all that kind of stuff. And then to answer your question, the way we're kind of really raising awareness about it, well, recently we've been awarded a large grant from the Wellcome Trust.
Yes.
A very large grant. And that is going to allow us to do a 2-day conference next June in London, bringing together around 400 people. And this is going to be scientists, clinicians, very importantly, people with lived experience, industry, regulators, just for anybody who's got an interest for 2 days. And there we're going to look at everything in the science of OCD, from new molecular targets to biomarkers, to digital interventions, to medical devices, to everything. And that is really about building the whole research community and putting OCD on the map so that people realize this is a very serious disorder. The science is really advanced, and there's huge potential for actually new treatments to help people, because it affects roughly anywhere between 2 and 4% of the population, depending on what studies you look at. So let's go for 3%, okay? That's up to 250 million people worldwide, of whom most will suffer in silence, because I often get asked, people say, well, if OCD is so bad, why don't we know more about it? There's a very good reason: the shame, okay? If you have a false memory that you've murdered somebody, you're not going to go telling everybody about it. You've got so much shame, linked to that and stuff. Or if you're worried that you might leave the tap on and flood the whole house and, or burn the house down, you're not going to say that. And because of that shame, people don't talk about it. So I have members of my support group who've lived with the worst obsessive thoughts for 30 years. And when they come to the group, we're the first people they've ever told.
Wow. That's very powerful.
Yeah.
So Nick, looking ahead, if Seranatis is successful with even one of its compounds, or hopefully more, what do you see is in the future? Do you see sticking with OCD and maybe moving to you talked about, other kinds of modalities of treatment, or do you see sort of segueing to a different kind of related disorder, addiction, anxiety, et cetera? What do you see for the future of Seranatis?
Well, my passion is these neglected mental disorders, which are very common. I mean, all the disorders are horrific. They're all as horrific as each other. When you have full-blown schizophrenia, full-blown OCD, full-blown bipolar, full-blown eating disorders and all that. But there's a lot of effort going into, schizophrenia, bipolar, and depression, all that. And so I don't really want to duplicate that. My interest is the other ones. Obviously, there's OCD. But within OCD, there is the whole OCD spectrum disorders. There's another one which is really, really horrific, which is body dysmorphic disorder. You know, this is where people start to, and it has obsessions and compulsions. That's why it's part of the OCD spectrum. But it's a separate disorder, and people will start to obsess about a part of their body, which for some reason they will think is just wrong. So it might be their nose, it might be their cheek, might be their arm, and all that kind of stuff. And then they will start compulsively checking and asking for reassurance. Of all the disorders, body dysmorphic disorder has the highest suicide rates.
Wow.
Higher than schizophrenia, high OCD has a high one, but BDD is higher than all of them, you know. And it has similar problems with neurocircuitry as in OCD, you know, and our compounds could potentially be used for that one. But then there's a few others. There's trichotillomania, which is hair pulling.
Yeah.
Like, it doesn't sound like much, you know, hair pulling, but people will end up quite severely disfigured, you know, with severe trichotillomania. And in 20% of cases, they will eat it. And then they might get stomach blockages and then surgery and stuff, you know. And then you get skin excoriation. So what they call dermatillomania, skin picking disorder, which again can lead to sepsis. You know, these are all part of the OCD spectrum disorders. So I'm very interested in developing these treatments that we've got for those other indications. And then another one that I'm really interested in is pathological gambling, you know, which has some overlap with addiction, but also with OCD. They use the pathological gambling Yale-Brown obsessive-compulsive score for pathological gambling. And one of the drugs we're working on could potentially work in that indication, for which there's no approved drug, you know, and it's devastating. People lose everything with pathological gambling. They just can't stop. So that's what I'm interested. I'm interested in all these kind of so far ignored, but yet devastating and very common mental illnesses.
So, okay, I have a question then for both of you. Do you think that the research and the science and the technologies that are being developed now that are very disruptive, in 50 years, we would be able to take a newborn baby or a child and understand their neurological makeup to have, you know, 5 classes of treatments that just from early on will transform the way a person lives? Because there's so much beautiful disruption going on right now. I'm curious about, you know, how this will unfold in the next 50 years, let's say. I'd love to hear from both of you what you think.
You go first, Nick.
Wow, that's a fascinating question. You know, that's an absolutely fascinating question. I mean, the way to answer it, I think early intervention is absolutely crucial, and we do not get enough of that. Our health systems are basically based on dealing with crises, you know, and again, I see that in the support group I run. You know, if people go to their doctor and say, you know, I'm not feeling very well and all that, they'll say, well, go back, come back in 6 months. If they go there and they say, I'm suicidal, this is it, this is the end, then they get helped and all that. What you really want is early intervention. And we know that's important in OCD. We know that the sooner you intervene, the much higher chance of success. And the reason for that is, you know, I have a memoir support group. Well, during COVID, actually, we all went on Zoom. And one woman joined. She hadn't left her front room in 30 years. You know, she was in her 60s or 70s.
Wow.
And by then, it's kind of, unfortunately, it's very difficult to do anything by that stage. But if you intervene when someone starts to develop their symptoms, you know, generally around late adolescence, but sometimes much younger, and you intervene well, then actually the person can have a very good quality of life. So to answer your question, I would hope in 50 years' times, I would hope we have great medications, you know, great digital interventions, great medical devices and all that. But really what I really hope is that we have very early diagnosis and very early intervention, particularly actually with good psychological interventions, you know, good psychological ones. And one of the things that we are funding through Orchard is a very, very exciting project by a really bright PhD student here at the University of Cambridge, who also works for Orchard. She is looking at the overlap between trauma and OCD, which is significant, you know, and where it leads to these kind of obsessive traumatic memories going round and round and round. And she's looking at a number of interventions that could work really well, you know, in that psychological interventions. And that the earlier you start, the higher chance of success. So really, I would hope we'd have a society which would look for that, diagnose early and intervene very quickly, you know, and very effectively.
Yeah, no, I think I agree with all of that. And I guess the only thing I'd add is our knowledge of the genome is going to just, be explosive in our ability to intervene early. So I think, every newborn is going to have, certainly I don't think 50 years, I think in the next 10 years, I think every newborn is going to be sequenced and you're going to know the entire genome. And from the genome, you're going to understand all kinds of areas where our science allows us to intervene early and to make a difference. And I think that's going to be the revolution. Nick, Jody and I have a tradition on Exploring Reality Maybe to talk about the ego. And I think it's particularly relevant with your sort of area of focus and, but tell us, what do you think, what does the ego represent to you? And how do you see understanding the ego, what it's like to be someone? What do or whatever you do see as the ego, how do you see that as relevant maybe to your work and your philosophy as a scientist?
So do you mean the ego like in your sense of self and of who you are?
Yeah, like in a Freud, we always sort of think of it in a Freudian sense, and yeah, like who you think you are, but however you want to interpret the notion of the ego.
That's a fascinating one, because the reason I've become so fascinated by this neuroscience and also these mental disorders is that they go to the core of who we are as individuals, And what we soon realize is that a lot of what we do is really, we think we have a certain amount of consciousness and a certain amount of self-will. I think we actually have much less than we believe, And I remember watching a program on consciousness and all that, and the ego actually a few years ago on TV, where they spoke to all these neuroscientists, and they say, well, how much free will do we really have? And one of them said, if that's a piece of paper, and that's all your actions and behaviors and thoughts and everything, your free will is that little bit down there. What it kind of made me realize is that you seem to have these different loops or circuits that are kind of triggering your thoughts and triggering your behavior, and which you actually have very little control over, And I found that kind of intriguing, but also slightly worrying, because you kind of realize that actually a lot of who we think we are and who we do are really just a product of our genes, of our environment, of all kinds of things. And we kind of think like, if you're successful, you think it's all due to myself. It's not really. It's due to all the people who've come years before. It's due to the context that you're in. It's due to the fortunate education. Maybe you've had caring parents. It's been to all those kinds of things, And so we shouldn't really become too arrogant or too self-obsessed, because a lot of it really comes down to good fortune. So to be honest, I don't know where I'm going with this.
Nick, I love it. I think it's one of the best answers we've gotten. It's great. It's really, it's right in the heart of our philosophy on the program. So thank you.
But the whole consciousness thing is absolutely fascinating. And that's a big thing, I think, at the moment, particularly with all the, what people are discovering with psychedelics and all that kind of stuff. It raises huge questions. And the final thing, actually, which is really interesting, as I told you, we have these EEG biomarkers, electroencephalography biomarkers, which are for our drugs. And one of them is this thing called the readiness potential, which is in the supplementary motor area. And I was reading about that, and I was really intrigued, because the readiness potential seems to spike when you're about to do something. But apparently it spikes before you're even conscious of doing something.
Yeah, I'm aware of those studies.
What does that mean?
Yeah.
Does that mean that our brain decides to do something before we actually know that we want to do it? And then we retrospectively think, I've decided to do that. I mean, what a question about self-will and self-determination. I'd love to spend, if I had more time, I would spend a lot of time reading about that and trying to figure out what it really means for who we are,
in mystical sense, in like a tantric kind of a understanding, supposedly there's out of nothing a spark. The ego sparks something. It's called ichi, and then our intellect steps in, jnana, and then we act on it eventually in that second kriya. And the idea is yogis practice being aware of the spark of out of nothing arising, like our senses, and then we stop. We practice stopping so that we stop it before we even know what it is, and we stop it before we act on it. And what I think about in terms of what you're describing is is like the practice of a firmness of the mind, so that if a negative spinning mind is going on and on and on, is there a practice of like firmness, a strength of the mind, let's say just to focus on the turn of the breath or a candle, or one pointedness on something, so that the mind, the negative spinning mind, stops spinning. And so I'm a teacher of meditation, so I explore this question of is the mind chemically induced to spin negatively, or can the mind be trained with more firmness to stop in its tracks the negative spinning thinking and focus on one kind, quiet space, like the space between two breaths. So I don't know the answer to that, but
there you have defined the very serenity which we crave for when we have.
I love it. Oh yeah.
Really
that's
do.
Good.
And I think if we could build that in from an early age, we'd build very strong resilience to these things.
Yes. Yes, I think so. Well, this has been an incredible conversation, Nick. I'm so moved by your work. It's going to transform just so many lives, and I look forward to seeing you. We met, of course, at the Real Mental Health Summit in London, and perhaps I'll see you here in New York. But it's incredible work, and we're here to support it. And our listeners can learn more about your work on our show notes on Exploring Reality on our website, Exploring Reality Maybe. And we just can't wait to follow up with you and see how these the research and the studies are going.
Well, thank you very much. It's been an absolute pleasure. Thank you.
Miraculix is a small and independent company that has created the first quantifiable home test called Q-Test for anyone taking mushrooms or psilocybin, LSD, MDMA, and any other psychoactive substance. So think about this. You're at home, you're with friends, you're hanging out, and you're experimenting with these amazing psychoactive plant medicines, and yet you don't really know the dosage. Miraculix is here to help you really have a positive experience so that you don't overdose. Created by Dr. Felix Bell of Germany, please go on our show notes and order this package. They're now available in the USA, and we couldn't be more excited to represent this home kit, because we want you to have a truly positive experience with psychoactives to explore your own reality and the way these psychoactives can help you in your life.
Exploring Reality Maybe is written, produced, fact-checked, and edited by Jody R. Weiss and David Schwartz. Research support is provided by Semicolon Connects. Music produced by Nextbox. Visit our website at exploringrealitymaybe.org to find show notes, transcripts, bios, and to learn more. If you like the show, please visit our website to donate.